let me move on to the next part of the conversation about this regimen. I agree that this is a new standard of care. I think HMA monotherapy should not even be considered for our patients anymore. But to put the benefit of this in perspective, we have to remember that in the United States, almost 2/3 of patients, at least half, over the age of 65, don't even get treated for AML. And that's because of the low response rates with HMAs. That's because we didn't really see a survival benefit with the HMAs. But this is different. I mean, we have a median survival of 15 months with Aza-Ven compared to 10 months with Aza alone. But not only that, the curves aren't coming together. That's what I find the most interesting, is that the curves aren't coming together. A few of those patients, 10%, did go on to get a transplant in the phase 1 study, but very, very few, I think 1 or 2 in the Viali-A study actually got a transplant. Now, we have to put this into context because this median survival of untreated patients with AML based on SEER registry data is 2 months. So it's not 15 months versus 10 months, it's 15 months versus 2 months. And we have to get away from the therapeutic nihilism in older AML patients. In fact, the greatest survival benefit was actually seen in those over the age of 75. Okay, so that's my commentary, but so now I want to bring it to, we won't see those response rates, we won't see that improvement in survival unless we manage the toxicities of this regimen the way they were managed on the clinical trial and really educate people how to do that. So I'm going to turn to Amir to start us on a conversation of what are some of the toxicities associated with this regimen, what are the pitfalls, what are the caveats, how do you get patients through this? Let's start with tumor lysis.
Well, that's an easy one. There isn't much tumor lysis with HMA and Venetoclax and AML. There is reports of some, so I think it's important to watch and be careful, especially with the first few doses. But it's much less common than what you would see, say, with chronic lymphocytic leukemia, in which scenario it's a much more challenging situation. Thank you, Harry, for allowing me to follow up the very pleasant and uplifting data associated with HMA-Ven with the challenges associated. I'm happy to do so because I do really think that there are some challenges with the combination. You know, I like the other folks on this panel, I work at an academic center. And I worry that this combination is now being pervasively used and increasingly used in the community. And one of the challenges with the combination of HMA and Venetoclax is the lack of consistency regarding the approach to its use. Do you give it for 4 weeks? Do you give it for 3 weeks? Do you give it for 2 weeks? I'm referring to Venetoclax. Do you pause after the first cycle of treatment? Do you do a marrow after the first cycle of treatment? And if you have low blasts, do you wait or do you continue? What do you do with additional drugs that may come on board? You know, for example, the azoles are the most common challenging drugs. These are scenarios that require a lot of education. And I do worry, based on what I have seen in my practice, that this degree of education and pervasiveness of knowledge is not yet there. So when you say that the amazing data we see in the phase 2 or the phase 3 data, I'm extremely happy about that. Like everybody else on this panel, I'm very reassured by the data that was presented 2 days ago, or 2 days ago. But I do worry that the real world is also very different when it comes to HMA-Ven, just as it is with HMA. I can't tell you how many patients we've admitted to our ICUs who've been treated in the community with HMA-Vens cycle after cycle after cycle and end up with severe marrow suppression infections, bleeding complications. So I do think ultimately what we need is a consistent approach to its treatment. I can tell you what I do, and I suspect it is probably similar to what other folks do here, and maybe not. There might be nuances, and that's part of the challenge. But what I do is I start with the 4 weeks of treatment with Venetoclax plus azacitidine or decitabine. And after the first 3.5, 4 weeks, I do a marrow biopsy to see what I have. If the marrow is empty, I allow count recovery and then resume. If it is full of blasts, I go with the second cycle. If marrow suppression happens—
Amir, let me hold you up for 1 second because you left out a very important clause. If the marrow is empty of blasts, you allow count recovery by holding the Venetoclax, right?
Of course. That's what I meant to say. holding the Venetoclax and basically waiting until starting the next cycle until there is count recovered. If this process of marrow suppression happens over and over again, there is a need, I believe, for decreasing the intensity of dosing. And generally, I reduce to 3 weeks or 2 weeks. Again, there is variability when it comes to that. Finally, with concurrent medications, such as with azoles, isofluconazole, voriconazole, posaconazole, you have to reduce the dose. And that is something else that I see in the community that doesn't always follow, even with fluconazole. It does require adjustment of dose, otherwise you're going to get in trouble with marrow suppression. So I don't think this is the equivalent of HMA when it comes to tolerability. It's not. I do think it's much better tolerated than induction chemotherapy, but it is less tolerated than HMA. Because of it, the enhancement in the efficacy and the improvement in the overall survival, I agree with my colleagues that it should be the new standard, but I don't agree that there are no patients in whom HMA alone is not appropriate. There are scenarios where patients who I'm really worried about marrow suppression and who have AML, I may still use decitabine or azacitidine.